Hi, Costas.
Hi, Sarah. Can you hear me?
Yes, I can. Yeah, looking good. I can see the slide.
Oh, perfect. This is what I wanted to check as well.
Yeah.
Yeah.
Happy to help.
Yeah.
Looking good.
Thank you, Jane. Okay. So shall we start, I guess, because we don't want to run out of time. So good morning, everybody, and welcome to the Geography of Mental Health Breakout. So my name is Konstantinos Daras, and I'm a postdoc research associate at the University of Liverpool, and also member of the Improving Population Health team. And in the next 40 minutes, together with our theme manager, Sami, we will go through our work in the IPH theme on data resources that we created on mental health. So, okay, let me make sure that my slide's working. So to give you a quick outline, this is going to be a two-part presentation. So in the first part, I'm going to give you an introduction to the Small Area Mental Health Index, then focus in a few areas in the Northwest Coast, Blackpool, Southport, Liverpool, and Knowsley. Then provide some examples of usage of Sami index, and I talk about some analysis that we've done on potential determinants related to mental health. And then we're gonna have 5 to 10 minutes of discussion around this topic, and move then to part 2, where I'm gonna present how we use the Sami index at the local level for evaluating interventions that aim to improve mental health in the local communities, and provide some examples of projects that we currently work in the IPH theme. And once again, we've used the remaining minutes to have a discussion around these topics. So starting with a brief background, according to the report from the Independent Mental Health Task Force to the NHS in England back in February 2016, 1 in 4 adults experience at least one diagnosable mental health problem in any given year. In this report, among other findings, they highlighted that 40% of the old people living in care homes are affected by depression. 1 in 10 children aged 5 to 16 years have a diagnosable mental health problem. But also they point out that there is a little or no national data available for how up to 67% of the mental health funding is used at the local level. They suggested that the right data must be collected and used to drive and evaluate progress. This begs the question that do we have the right data actually to make sure that we could be able to measure the mental health problems in our communities, and be able to evaluate interventions that they can improve the mental health of the local population. So thankfully, in England, we have a large number of data sources coming mainly from the NHS Digital that can give us a good measures to different dimensions of mental health. So we can have data from quality and outcomes framework on dementia prevalence and depression prevalence and other mental health problems. We have open data on prescribing, and more specific, we can have access on antidepressants at the GP practice level. We have information coming from the hospital episode statistics on hospital attendances related to mental health also. And there are the adult psychiatric mobility survey too, which is about 7,500 participants in this survey. Also, the ONS provides the annual population survey, the APS, which is actually has the one question related to mental health about anxiety. But looking up on all this data, we in IPH and our team, we figure out that we still need a longitudinal data set that will give us the ability to measure change of the mental health over time. This is how we developed the Small Area Mental Health Index, Sami, which is a composite longitudinal measure of population mental health for its lower super output area in England. So lower super output areas are about 1,500 people. And this index is a combination of 4 indicators. So we are put together the prescribing data with antidepressants, which is an open data set from NHS Digital, combining the depression prevalence from a COugH database. And also we have the mental health related hospital attendances coming from the hospital episode statistics. We also include the incapacity benefit and employment support allowance for mental illness, which is coming from the Department for Work and Pensions. So these 4 indicators, we're using factor analysis to bring them together and create a single measure that can help us to measure the mental health. So this data can be accessed from the place-based longitudinal data resource website. So you can see the link on the top left. Just as I promised in our title, we're going to talk about geographies, and this is 4 maps where we can see our 4 indicators and the patterns that are appearing in each of them. So dark colors always represent higher values. So this means, for example, for the left top map, dark red color, high antidepressants per person in these areas like north of the Norfolk and so on. And moving in this slide, we can see our small area mental health index. Red color represents the deciles with worse mental health, and blue color the deciles with best mental health. And if we zoom in the areas on Northwest Coast, then we can see that there is a coastal effect of areas with worse mental health and also concentrated in urban places. Focusing on Blackpool and Southport, once again, you can see in this slide the 4 maps or the 4 different indicators: antidepressants, depression prevalence, and hospital admission and INBESA measure. We can see the patterns that they are actually mainly in the Blackpool city and Southport. Once again, looking at a Sami index using the 2018 data, then we can see clearly the worst mental health areas are in Blackpool and Southport. But the most important with this index is that we have longitudinal information, and this gives us the ability to see the change of mental health over time from 2011 to 2018. So once again, with the dark pink color, you can see the center of Blackpool and Southport that they actually are getting worse over time in terms of mental health. And if we want to contrast that with deprivation index here with dark brown color, we can see the most deprived areas, and we can see that there's a really similar pattern to give us a really good indication of the relationship between deprivation and mental health. Another example is the Liverpool and Knowsley. Once again, we have the antidepressants that for the 4 indicators that can give us a really good information about the patterns in this area. And looking at the Sami index, then we can see that the city of Liverpool, the city center of Liverpool and the southeast area, they are having better mental health compared to the rest of Liverpool, Knowsley and Wirral. Once again, looking how the score changed over time, and we can see that Liverpool city center and the southeast areas of Liverpool have an improvement in mental health over time, while the north Liverpool and Knowsley and of course Wirral is getting worse over time. And once again, to contrast with our deprivation index, then we can see again similar patterns with those from mental health index. So that was just a few examples. So for those that they were really interested to see other areas and how they perform, then they can go to this link and they can actually play around and see for themselves, the data and of course see the maps and how these areas perform. Just moving on and talk a little bit about some examples of usage of the Sami index. As Mark mentioned in his introduction, we had the Sami index used in 2 reports related to the impact of COVID-19 in mental health. The first one was for the all-party parliamentary group, and here the left behind neighborhoods have been highlighted as worse. They have more worse mental health compared to other deprived areas in England, and in the North Health Science Alliance report, poor mental health is clustered. They highlighted that the poor mental health is clustered in disadvantaged post-industrial areas in the north, with mental health problems 74% higher in north and the south, and 39% of the northern neighborhoods in the 2 worst deciles of our Sami index. So once again, these 2 links can be visited to see more about these 2 reports. And moving on the change over time of mental health for all the England, then Sami can help us to see here, for example, in this diagram, how much the mental health gets worse. So we can see that there is a steady increase of the Sami score over time. This means that there is a decline of the mental health in all England, and trying to understand the reasons behind that, we look for some potential determinants in this presentation. So we focus on on 5 age groups with data coming from the census 2011. The distance from the main retail center, that's data coming from the Consumers Data Research Center. And also we use the employment deprivation domain from the IMD 2019. So from our analysis, as we can see in the diagram here, all of the determinants were indicated significant at the 99% level. So Some findings from this analysis was that the mental health gets worse over time in areas that experience high employment deprivation. Also gets worse over time in areas that have a high percentage of population age 70 plus. And also we can see that the mental health gets better in areas that are distant from main retail centers. So I'll stop the presentation here, and I hope that we can start the discussion. And if you want to ask me anything about the Sami index or anything else, so we can start our conversation now, and then we continue with a sort of presentation afterwards. So I'm going to stop sharing now, and happy to answer any questions. Do you?
Is any of this information shareable, Konstantinos? Because I think it'd be fascinating for some of our place-based teams across the Northwest Coast.
Yes, just to help you with my name, first of all, you can call me Kostas. It's much easier. Sorry for that. And
apologies.
No, it's all right. And yes, all this information is available. You can find it in the PLDR website. All the maps that I presented in this presentation are available on the CartoDB platform, where you can go and visit and look around, other areas aside from the four areas that I show you in this presentation. And the only thing that I need to mention here is that the Sami index that I'm presented right now is the latest version of the index. In our PLDR website, we have a previous one that we followed the method much closer to the one that was used in the IMD. And the way that we changed our methodology was that because we wanted to be able to capture the change over time of the mental health, so we made our indicator, let's say, better in terms of capturing this aspect of mental health.
Hi, Kostas.
Hi.
Hi,
I
was just intrigued about the last slide where it was related to the distance from a retail area. Wondered if you want to say a little bit more about that and what you think is possibly happening there.
I think the majority of the main retail centers are concentrated in city centers. So I think it's more kind of what we're capturing there is actually, as you are moving away from the city center, then mental health is not, is not related to the. I think that's a good relation about the urban rural kind of category division, say. And I think certainly we need to look at it more. This is just a few determinants that we looked at, and of course we need to have a better look. So that's why I just throw this analysis in this presentation just to start a conversation and see what other people think about what we've done, and whether we can use other data sources or other determinants that they might be useful to improve the index or our analysis in terms of say, or find some interesting findings in terms of the mental health.
Costas,
Yes.
can you hear me?
I guess I can hear you, son.
Oh, you just answered me, so yeah, you obviously. This Emma Stubbington has put in the chat, when an LSOA contains a long-term residential mental health facility, how is this accounted for in the Sami index calculation?
Long-term, I'm trying to understand again. Can you repeat the question again? I'm just...
Sorry. When an LSOA contains a long-term residential mental health facility, how is it accounted for in the Sami index calculation?
I'm not quite sure about the facility, what they mean, but I suspect that all this comes from the 4 indicators that we have available, that are public they are available from the different data sources that we have in our organization. But I think that this is just represents what is the situation in terms of mental health in each LSOA. Doesn't explain, why the mental health appears there, or what is facilitated behind all this. I'm not sure if I answered the question, but if they want, come back and help me understand better, maybe I can provide a better answer.
Hello.
Hello.
Can you hear? I asked a question. So what I mean by this is when you have long-term mental health patients, they'll be based in a facility which tends to be maybe we have one in Lancaster that's just on the edge of Lancaster, and so you'd expect everyone who is living there to be have sort of very high factors in your score, so they would definitely be on antidepressants, so you'd have lots of prescribing data for them, and they might be on incapacity benefit, and so you'd expect that area would then have a higher score than if that facility was, say, placed in a neighbouring LSOA. So I was just wondering if you'd accounted for this when you calculated the index, because it could be skewing some areas where it's actually people sort of long-term residents there, if that makes sense.
I understand what you mean. I think, you need, first of all, to have data about that, so that you can be able to do that. And I don't think that that would gonna alter much the index, because actually the index represents the population, the residents of the population, and so it's highlighting, areas where they have, this high or low, depending on the area, mental health issues. So I don't know whether that would be actually affecting them, the index, in a bigger percentage, because even if you count about it, still you want to measure. I'm not sure how you can do that, to be honest. I think we can have a discussion on that at some point and see if that's actually improve our index. That's actually a really good point. Have to look at it.
Hi, Kostas, it's George. It's more of an observation, really. We knew about the overprescribing of antidepressants in Blackpool, and I noticed on the map you were showing East Anglia was nice and bright, and northeast, northeast of England as well. But also, was West Yorkshire in there as well as an area that seemed to see an overprescribing of antidepressants and obviously subsequently mental health problems?
Yes.
Yeah, I thought I spotted that.
Yeah, no, I mean, that's the thing. And I mean, probably you have seen in the 4 maps that there are quite a few patterns that they are, they are the same in all these 4 indicators. Bear in mind that this index uses only these 4 indicators to capture just a part of the dimensions of mental health. Yeah. So we probably we need to do more work and add more more indicators that can give us a better view about in terms of the whole mental health problems. And but that's once again, it's a matter of the right data, right? So you have to find data that first you have a longitudinal information, so over time, and then you are in the right quality that they can give you quality information at the small area level, at the local level, because you want this index to be used not only for just highlighting areas, but also to be able to evaluate interventions that they aim to improve the mental health. So yeah.
Yeah, no, because we knew about the coastal communities, obviously, which I assume that's where the northeast ones are coming in, and the ones in the East Anglia. But yeah, it just came as a surprise to me. So yeah, thank you. That was really interesting.
Mm-hmm. So I'll continue with the second part, which is a very short presentation, and then we can continue with questions and if any discussion that you would like to have. So I'm gonna try to share again my screen, and okay, so in the second part, what I would like to talk about is about how we use the Sami index at the local level for evaluating the interventions to improve the mental health at the local communities. So in our team, what we tend to use is the quasi-experimental methodology, which call it difference in differences, and that's a widely used method in econometrics and increasingly in health research. This gives us the ability to use it at the real world setting. So just to give you just a brief introduction on differences and how it works is to use the difference in differences, we need observed outcomes that can be the Sami index or any other outcome of the areas who were exposed to the intervention, and the areas not exposed to the intervention are called controlled areas or control group, if you like, both before and after the intervention. So having this, we can estimate the effect of the new intervention by comparing how the Sami score, for example, in a study area changed before and after its implementation. And we use this methodology to a few projects that we work in the IP8, and one of them is the community control, where we investigate the impact of big local initiatives on mental health outcomes. Another project that is gonna start next April is a community wealth initiative, where we estimate the impact of Preston initiative on the primary outcomes, which is the small area, among them is the small area mental health index. And a third project is the self-harm project on impact of the HOPE initiative, which started in 2017 on hospital admissions for self-harm across Liverpool. So this is just how we work in terms of at the local level using the Sami index at the moment. And I'll just stop here, and then we probably will be able to have some more questions and discuss on what else we should be looking at, and or what you would like the Sami help with, and so on. So if we have any more questions, happy to answer them. Do you have any questions? We can continue in the previous topic on the Sami index as well. Happy to answer any questions related or potential determinants that you think that maybe drive the increase of mental health, or what you would like to see, for example, to explore further in our analysis.
Looking at your map again, were you surprised at the results for London? I wondered if you could talk a bit about that.
In terms of mental health, that is very low.
Yeah, as in the sort of overall colouring of it looked like it was very low. And if you zoom in, there's a few areas with sort of a red in the 10th decile.
Well, that's quite a common kind of map, let's say, trick. When you are at a high level, the aggregation and all the information is, it's just driven by the size of the area. So you can see, for example, the rural areas to be, have a really nice big, blue colors, and some pockets, especially in urban areas where they have, poor mental health, they can be hidden. So probably that's the case in London, but and that can be for all the indicators. And of course, mapping is just for exploratory analysis. It's more on identify where the patterns are, and then dive in this area and try to figure out why these patterns appear in this area by looking possible potential determinants that related to this to mental health in this case, or any other outcome that you're looking at. So I would say that when we are looking at maps, we need to be careful on this, on the size of the areas and how we interpret everything. But yeah, that would be my answer. In terms of the London, yeah, well, in general, has much better mental health in terms of scores, and that's clear. And if you see it, for example, north-south measures, they show that they were clearly, the north has a poorer mental health in general. And that's not according only to the Sami index, but we can see it in the literature review quite clear as well.
Can I make a comment, Costas?
Yes, of course. Yeah.
Hi, everyone. Sarah Rogers. And I guess the important bit, just following on from what Costas is saying, is that the place-based longitudinal data resource has a time element to it. So once you've got that, then you can try and get to more towards causality and try and work out the chicken and the egg, what caused what, so that you don't just look at statistical correlations, but you try and look to see when the COVID pandemic happened and then what happened to the mental health of the population. So you have the incident or exposure before the outcome that you measure, and I think that's the important one of the novelties of the place-based longitudinal data resource, as well as the spatial element, of course. It's the longitudinal bit. So that's really hard to put together, as Costas was saying, with all the data quality needs to go into that. So it's a really terrific resource. So if anyone wants to use it, then get in touch.
Yeah. Thanks, Sarah. Yes, that's true.
And I guess it has been already used, hasn't it, by and quoted in some COVID type reports, for instance. It's been picked up nationally, hasn't it? So they're making
yes, there is a number of local authorities that they have using it for COVID-related reports and trying to see, the mental health of the neighborhoods in their local area and try to, see vulnerable, let's say, areas and how they can, make a policy for the future, or see how they can work with these areas and so on. So yeah, that's right. I mean, it's in terms of the importance of PLDR and the Sami index in more specific, is that you have the time element, you have this longitudinal information that actually gives you the ability to look at the change over time. And then this one is really valuable when you want to evaluate interventions in the local areas. Which is something that is really difficult because the majority of the data are kind of like snapshots of a time period, of a time, and you don't have this time element that can help you, to evaluate these interventions.
I think that's really important to stress the use of routine data here, data that are collected anyway, because I was just talking to a lady yesterday. She collects the data for the National Survey for Wales. And it was a household survey, and the difficulties of actually going to people's houses, of course, during the pandemic has meant that there's not a continuous before and after measure of mental health and well-being other than in the routine data. So actually having hospital admissions and prescribing data and things like that can actually allow us to get a before and after measure, which is really important to see actually what has happened, because there's so many things that have happened this last year that you just, it's made all the household surveys go a bit awry, go wrong, as the policy lady from the Natural Survey for Wales.
And even for the national indicators that we have and we use, for example, in the Sami, still we have, because of the COVID and the changes in everything that happened in NHS in this last, since March, then the data, the quality of the data changed. It's not, you cannot use, for example, 2020 data to say things anymore, because many things changes in NHS, the way that they're recording, or people, for example, they didn't visit NHS for the, for regular visits. So all these things are affecting the quality of your data and how
our data.
Yeah, exactly.
Make things complicated. Yes, I agree.
Yeah, true. Yeah.
Thanks very much, Costas.
Thank you, everybody. I think, we wrap up this now and then probably move to the other room with Ben. Thank you very much. See you soon. Bye.